My disclosures, most significant of which is my role on the International Spine Study Group, working to develop and potentially commercialize some of these calculators. If you think for a moment about if you were in, for example, a think tank, or you were in a development meeting with industry, how you might make spine surgery better, safer, and less variable in the future, how do you think you would do that? Is it going to be through implant innovation? Is it going to be through the development of enabling technology? Is it going to be through more effective teaching of advanced techniques, or maybe something different? Well, if you talk to the implant companies, although in fairness, some of them are starting to think a little bit more along the enabling technology scheme of things, they're still very, very much focused on monetizing things you put in patients. And even software and enabling technology seems to be always intimately tied to an implant that they can monetize. But I would argue we need to start thinking really in a different way, especially if you think about the history of what's gone on with iterative improvement over the last 10 years in pedicle screws. It really hasn't helped us tremendously, at least since the first 5 to 10 years after the multi-axial screw was developed. One way you might think is to make surgeons better, maybe through more effective teaching, et cetera, but actually the ultimate bounds of human performance can actually be predicted. We know we're going to run up against a wall, for example, very unlikely based upon predictive analytics and AI to ever get under an 8-second 100 meters. And do we really think like the next generation of surgeons are going to be better than, a Larry Lanke, for example? Probably not. We're going to have to help surgeons along the way. And also that's only one surgeon or 1 or 5 surgeons that you might say, okay, these guys are technical masters, but they're not treating the majority of patients. There are a lot of surgeons around the world that are providing care. And then we have this issue going on with respect to quality benchmarking. The number of doctors around the country has really been increasing at a much lower rate. This explosion of administrators that go out and do their online education and get these online degrees, say they're MHAs, and they have expertise in administration. They're trying to tell the doctors, how to benchmark their quality, and they really have no idea what they're doing. But because of HIPAA and all these other HCAP and all these other scores, the hospitals have had to hire these people that really have no expertise in medicine, and we have to report to them. And I'll talk about that in a moment. And then finally, and this makes some sense as to where things are going, it used to be when I was a resident, this is more than 20 years ago, it was just kind of accepted that, the younger surgeons may have different outcomes from the more experienced surgeons. And although that may still be the case to some extent today, it's really no longer acceptable. I mean, that's gone away. The days of the residents running crazy, running independent in rooms and things, those days are over. When you get on a plane, if you see a young pilot, if you see an old pilot, the technology on that plane has to make that just as safe for you. There can't be any difference between those two flights. The same is true, is going to be true for surgeons. And then we have this issue, and by 2050, there are going to be 83 million people over 65. Medicare is going to be providing the majority of the financing of the complex surgery for these people. And there's a 60% prevalence of degenerative scoliosis. That means we're going to be treating a lot of degenerative scoliosis. Currently, there are about 50,000 cases of ASD surgery done per year. That's about 125 billion spend using 2019 numbers. And it's up against an exponential growth of the percent of GDP that healthcare takes up in the United States. And this is really just unsustainable. Medicare was estimated a few years ago to become insolvent by 2026. And again, Medicare is providing most of the financing of these cases, particularly later in life. Many of these patients are over 65. This is just not sustainable. So what are we going to do? We have to figure out different strategies beyond just monetizing implants that's going to make these surgeries cost-effective, safer. And we also have to do our own benchmarking. We can't rely on somebody, right out of an MHA program, right out of undergraduate school, that's going to tell experienced surgeons how to do things and how to monitor our quality. We have to be advocates for ourselves. So if you look on the right, those are the FDA approvals utilizing AI in medicine in the United States in the last couple of years. Most have been in histology, radiology, pathology. Some are starting to make their way into diabetes care, et cetera. But it's really starting to take off. Information is in many ways really the ultimate enabling technology. If you think about navigation, again, when I was a resident, I remember clearly one of my attendings say, the only surgeons that use navigation for brain surgery don't know their anatomy. Okay, and the same has been said for spine surgery, right? If you need navigation, you just don't know the anatomy, of the pedicles. And it's just completely ridiculous. It's become an intimate and key part about making these surgeries safer for patients, enabling us to push boundaries and put screws in fusion masses and do extreme types of surgery. The same is going to be true for information as an enabling technology, being able to look at an older patient in clinic and in real time, like a Terminator mask, say, this is your predicted future. If I do this operation, this is your likely risk. This is your likely benefit. If I do this operation, the same. Not based upon my opinion and my, unreliable recollection as a human and one single doctor who maybe would treat maybe, 40,000 patients in my career, maybe just see them in clinic. I don't know. No, over looking at worldwide databases of thousand cell data analysis per patient, the machines are going to tell us much better what to do in the future for these patients. Well, one way to go about this is utilizing something called, collective intelligence, these multidisciplinary panels. And there's the classic experiment for this was a jelly bean experiment where you take 56 people and they can usually judge within 3% the total number of jelly beans in the jar if you average their opinions. And this is similar to multidisciplinary panels, for example, like spine team approaches, tumor boards, where people kind of balance themselves out and they eliminate outliers to some extent. As I've traveled around the world and given these talks on AI in medicine, I just gave one at the G20 meeting. Surgeons often say, well, how can we trust the AI to be accurate? I know what's best for my patient. I have a relationship with that patient. I can best predict the risk and outcome. Well, if you look at the data, just like many things, it's completely untrue. There have been many, many studies showing that surgeons are very poor at predicting risk and outcome. This is one from general surgery. This is work that from Police and I did on adult spinal deformity surgery. It's a survey-based study showing that when surgeons were given cases across all domains of experience, we have surgeons in the ISSG and ESSG that are 5 years out, some more than 15 years out, like myself. And many of these surgeons have treated many, many patients. And this is a sample of like what we would give them to make a risk and benefit prediction. And we look at what they did, we see that their standard deviations for the risk and benefit are all over the place and don't have any specific correlation to reality in terms of what the actual outcome was for that patient. And then when we look at correlations between surgeons, we see they're all weak to very minimally moderately correlating. So obviously there's heterogeneity here in what's going on. And when we look at the correlation between the calculator and the surgeon, again, this is a parameter called the mean index of agreement. There's very minimal index of agreement, with one being, perfect agreement, very poor agreement between accurate predictors and surgeon prediction. What you could operate on someone without, giving them a risk score, but try to get a house or a mortgage or a car without going through a very sophisticated risk prediction process. It's just not going to happen. And in the future, the same is going to occur with surgery. This is work we did that probably you're familiar with on frailty, showing that using a 40-point frailty score, good correlation to major complication. And essentially, this is a predictive review of systems. It's been integrated into our medical records. It's a core part of our real-time point-of-care risk assessment in clinic. And before we even see the patient, we get data on their risk of major complication and their risk of an increased length of stay. And now I'd like to talk about, how the surgeon sees the patient versus the machine. So if you look on the left, this is a sophisticated surgeon. He's giving the patient a frailty score, an ODI, an SVA, et cetera. And on the right is what the machine can do. This is what's so different. So the machine sees the patient immediately in the context of the patients that are like that patient. They can generate a list of the most similar 10 patients, the most similar 100 patients based on hundreds of variables, and pull out X-ray data, what was done for that patient. That's just not possible for human intelligence to do that. Based upon that, we developed an adult spinal deformity classification. It's no longer based on weak correlations to the sagittal plane, as the Schwab SRS was, but actually is based on real risk and benefit based on machine learning. The machine assigns the patient a category of patient. They assign them a category of surgery. Once this has been classified by the computer, you can look on there and pick out the likelihood of ODI improvement, the likelihood of major complication. We joined forces with the European group several years ago to develop a worldwide predictive modeling initiative. We've recently launched groups in Asia, also in Latin America. I was just talking to Juan Emmerich about expanding the Latin American database a few days ago when I was down in Mexico at the SRS course. And essentially what we've been able to do is this: across 17 different hospitals now with close to 3,000 patients, we've been able to develop predictive models of risk, developing a precision calculation of the patient's individualized risk of surgery based on hundreds of variables at every time point from point zero, the time of surgery, out to 2-year follow-up. Now, what about outcome? Surgeons are even worse, actually, at predicting the outcome of patients. You can look at an old, frail patient in clinic and think, okay, that patient's probably at some increased risk of complication. We're not good at predicting actually what it is, but we can say, wow, that's a riskier patient. The outcome, even worse. And so how are you going to tell a patient what the outcome of surgery is likely to be? Well, if you're good, you would pull out maybe a paper, maybe an ISSG paper like this one, and you would quote them an average value. On average, your ODI is likely to decrease from 30 to 15, for example, based upon this paper. But actually, we see tremendously heterogeneous outcomes within the data set, with some patients really massively improving, some patients with significant deterioration, and only 5% of patients had what you would call an average improvement. So you're essentially, if you quote them an average improvement, you're lying to 95% of the patients. That's just not an accurate way to do it. So a better way to do it is with machine intelligence, where we can predict with about 75% accuracy the outcome at 2-year follow-up with SRS-22, ODI, SF-36, MCS, and PCS, up to 82% predictive power. And one interesting thing is if you look at the weighted variables that have the most influence on outcome, you don't find the sagittal plane anywhere in the top 10. That's a subject for a different talk, but I'll just throw that out there. Now let's look at a modern workflow. We identify the patient's clustered. Similar patients are pulled out potentially. Then you enter the demographic data, the comorbidity data, the radiographic parameters, the disability index data, which is essentially establishing a baseline level of function. It's called disability, but it's really a functional datafication of the patient. And then you enter the procedure, and this is what you get. This is our calculators as they exist today on the web. You get a plot of the patient's major complication risk. You get a plot of the readmission and reoperation risk at every time point from time 0 out to 2 years. And you get an estimation of the HRQL outcomes. And this is what we did for this particular patient who had a 3-column osteotomy. Finally, and Shay wanted me to address how this particularly applies to quality comparison. One thing we see, again, with these administrators and, now with the government reporting is they love to publish things like this online. So you look at UCSF, it doesn't seem like we're performing quite as well as CPMC. If you look at UCLA, another big tertiary care facility in California, these are very highly ranked hospitals. It doesn't seem like we're performing as well for spine surgery as, for example, Cedars. Now, Cedars actually has some more deformity surgeons than, for example, CPMC does. But the idea is really that these tertiary facilities that are taking on these very complex cases are not really receiving the credit and the appropriate stratification that would indicate that, and why their quality metrics as reported to the government may be slightly different. So let's look at PJK, for example. If we're it's the most common cause for reoperation in the adult spinal deformity patient, since Vanco powder has basically decreased wound infections. So let's look at this. So how would you tell an outlier in PJK or PJF? Well, the way we used to do it was you would determine the average value of PJK, PJF from a paper, and then you would draw a line across all the different sites, and you'd say, okay, site 7, site 10, 8 are underperforming sites. Their PJF rate is way too high based on the average value. And we identify the outliers that way. And, the administrator would go to those sites and say, you need to get your PJF rates down. Your reoperation rate for that is way too high. But utilizing predictive modeling, you can actually go in and say, based upon 50 or 70 different variables, based upon the patient's frailty, the sarcopenia, the comorbidity, the osteoporosis, the procedure done, the severity of pre-op deformity, then we go back and we can predict what would likely be the risk of PJF at each individual site based upon their particular patient population. And we see that the underperforming sites have changed. And site 10 actually doesn't look quite as bad. It looks a lot better. It's still underperforming slightly, but still it's indicating that those sites that seem to be underperformers were actually treating much more complicated patients that would be predicted to have higher rates of PJK and PJF. And interestingly, some sites that seem to be overperformers without using predictive models are actually just seeing simpler patients, and they're actually underperforming in those simpler patient populations. They're actually not doing a good job, even though their PJF rates are less than average. And the only way to do this is with predictive modeling, with AI, to benchmark. You can't do it just using just simple reoperation rates and things like that. That is, these guys right out of University of Phoenix or some of these online MHA courses that they're trying to take. Come in and try to do this. And then if we look at pseudoarthrosis, we did the same thing. We published a model in pseudoarthrosis. We apply this model of pseudoarthrosis to the different sites. And we see that it's very different from just applying an average value. Some sites may be treating patients with poor bone quality, osteoporosis, et cetera. And we see that some sites that seem to be, you would say their pseudoarthrosis rates are less than average, they're overperforming, they're actually not doing a good job based upon what you would predict their pseudoarthrosis rate should be. So predictive models are going to be the future for benchmarking of major complications reoperation, and are going to allow better quality comparisons among hospitals. And I'll just finish up with this one slide showing that now that we can predict risk and outcome at the population level, we can start to make filters of who we want to operate on. So if you say, I'm going to accept a 50% complication rate, but only I must achieve MCID more than 50% of the time, then you can look at changes in rates of surgery and changes in costs at the population level, simulating with the impact of that in your particular population. What could be the government of Spain or government of the US or the government of India, et cetera. They don't have to repeat all the mistakes that have been made in the United States. These models can be applied in first and third world economies all around the world to try to optimize care within a limited budget. And thank you very much for the opportunity. I've run out of time to talk really about prehab and all that, but it's a key part of our process. And some of our work in the future is moving toward genetic analysis, which may be even more predictive than frailty, and we're presenting that at the SRS this year. Thanks so much.